Hello everyone. So we will start the session, and today's topic is what are the new reforms which are going to be there from June 2025 session. So I'll be conducting the Viva part and Longs part, and then Dr. Bharat will join us and he'll comment upon the shorts part of the section, which is a new part of the FRCR 2B exam, the final FRCR 2B exam. So without waiting any further, I think we'll shall start the session. So we'll discuss about the Viva first, Viva or oral part of the examination. So the pattern will be the same. There will be two rooms. In each room, there will be two examiners, and each examiner will have 15 minutes. And in those 15 minutes, both the examiners will assess the exam going candidate. And the new part of this FRCR 2B exam, which is going to be there from June 2025 session, is each examiner will only show you three cases. So for four examiners, there will be total of 12 cases. And what they have mentioned on the website, on RCR website, is that they will be having a dedicated question bank, and whatever students are there on one particular day will have similar 12 cases all across the world. This is just to standardize the process of FRCR 2B examination. Okay, guys. So the people which are going to give exam next day will have a separate similar 12 cases all across the world. So now the exam, the Viva part will run, I think, over a period of 1 week. So they'll be having such a similar set of 12 cases for each day, so that the examiner will not, the candidates will not have any, so the candidates will not have any discrepancy, and candidate will, the examination will not cause any issues. Okay. The exam will be conducted on MS Teams only. So I think this part we have covered it in detail. So the new portion of FRCR 2B exam is the examiner is going to assess the candidate based on these five domains. So the first domain is radiology knowledge. So these domains were not there till now. They have added it for standardization of examination, the Viva part. So the first domain is radiological knowledge. Second is observation, whether the candidate is able to pinpoint each and every abnormality in the scan. And then the clinical reasoning, whether how is the clinical reasoning of the candidate, the clinical safety and the management part. And this is the new part which they have implemented from June 2025 session, is this communication, whether the candidate is able to communicate properly to the colleague, the positive findings, negative findings, and how the radiologist is going to further manage the case. So that is more important. So right now this communication part was not there till the March session, but I think from June they have added this new section in assessment domains of the FRCR 2B final exam, and each examiner will assess the candidate separately. So the marking system has also changed from June 2025. So they have divided the marking system in this five part. First is excellent, second is clear pass, third is just pass, fourth is borderline fail, and fifth one is fail. So excellent is above than the expected. The candidate has performed above than the expected level, which is needed in order to pass the examination. Then the clear pass is candidate has identified predominantly overall all the positive findings and mention all the negative findings, has done few of the minor negative mistakes in the examination, but however the candidate is competent enough to give the answer, to reach to the diagnosis and properly manage the case. Just pass is like the candidate has identified and performed well above just the passing level by a small margin. Some of the positive characteristics the candidate has identified without the need of prompting. Some of the negative characteristics the candidate has mentioned in the viva part, but those are not dangerous in to the patient in further management. Okay, so this should, so by this it means that even if there is a pneumothorax, if the candidate has not picked it up, that means that is dangerous to the patient. Okay, so some of the things, some of the negative characteristics which the candidate has uh, not pointed out or might have mislabeled it, but it is not dangerous to the patient, that that will come under just pass category. And the candidate has shown minimum level of competence in order to pass the examination. Borderline fail and fail is like no predominance of all the positive or negative findings. Negative characteristics displayed, not potentially harmful to the patients, and barely adequate level of competence. That means the if you read it again, it sounds like the candidate has not yet reached to the margin where the examiners will pass the candidate the final to be in the final to be examination. Fail is like negative domain characteristics. The candidate has not identified any positive and not mentioned any negative findings. Negative domain characteristics which the candidate has mentioned in the report, or miss some important positive findings, that is potentially harmful to the patient. If there is a midline shift and the candidate has not mentioned it and did not convey it to the referring physician, that means the candidate is causing potential harm to the patient in further management, and the adequate competence is not achieved from the candidate's part. So in order, so in order to score this excellent, clear pass, just pass, borderline fail and fail, these RCR examination, they have decided to label each and every category of excellent given as a band 4, then clear pass is band 3, just pass is 2, borderline fail is 1, and fail is 0. So 4, 3, 2, 1 and 0, like that. This is just an example how the candidate is going to get scored in the final FRCR 2B examination from one examiner. So from 4 examiner, the candidate will have 4 such sheets, and the final sheet will be average of all these. So the knowledge like excellent, clear pass, just pass and borderline fail. So we have to keep in mind that we don't have to come under the category of borderline fail and fail if the candidate wants to pass the examination. That means the candidate uh, should identify all the positive and negative findings well above the adequate competency level by a small margin. Candidate should be able to positively characterize the diagnosis and the management part without the need for prompting. And the negative characteristic candidates might show, but it should not be dangerous to the patient and also in the further management of the patient. And the candidate should be showing a minimum level of competence in order to pass the examination. And the other part, the communication part with the which the RCR examination has recently included is so from all the 6 cases, the communication part from all the 4 from the 2 viva room, the communication will be multiplied. So it will be multiplied by 6. So for 6 cases, the communication, the examiner is going to mark the candidate based on this: excellent, clear pass, just pass, borderline fail and fail. So the communication is also categorized into these 4-5 types. So finally, communication score is assessed per station and it is multiplied by 6. Maximum score given to the candidate for viva part is 450. So amongst the 2 examiner, difference up to the 5 marks is permitted. if there is difference of 6 or more than 6, then then the candidate and the final sheet of the examiners and the viva part will have to be reviewed again by the RCR, and the discussion will happen to reach a proper final outcome, so that the difference should not be more than 5 marks. This will help the candidate if one of the examiner has given just 4 and the other examiner has given 7. So that should not happen in the final examination. So the pass mark for viva is 281, which equals to 58.5%. Okay. So this viva part is done. Now we'll move on to the longs part. So I'll be conducting longs, and then we'll move on to Dr. Bharat's side. He'll be showing what are the changes made in the rapid part, and the rapid section is replaced by the shorts. So in longs also, the basic format is the same. There are hardly any differences. Only the marking system has changed a little bit. So the candidate will be shown 6 cases with various modalities, 5 marks per case, no half marks will be given. So total 6 cases, 5 marks each, so 30 marks in total. 2 examiners will independently double mark the answer sheet of the candidate, so that there will not be any discrepancy from one particular examiner, and the final marks will be average of the 2 examiners which the candidate has received. So the markings framework permits a difference of up to the 1 mark between the 2 examiner. Any score difference of 2 or more than 2 will be flagged for review and discussion, so that the candidate should be getting a proper marks from both the examiners. There should not be any discrepancy from examiner side, like one examiner is giving fail and the other examiner is giving excellent. So that should not happen in the examination according to the new marking system. So the score mark is like we have discussed. So total 5 marks per case. So that means they are going to categorize these 5 marks 1, 2, 3, 4, 5 separately. So the 5 score will be given to the candidate who is going to detect all the major findings and most of the minor observations. So minor observations will include, I guess, some aortic wall calcification or some renal cyst or some calculi within the kidney, or some degenerative changes, some spondylolysis, such minor observations. So the 5 marks will be given to such candidate. Then in order to get 5 marks, the candidate has to make correct diagnosis and give correct differential diagnosis using clinical information provided. The management is further management given by the candidate should be clear with proper recommendations. So that includes MDT, specialist referral if appropriate. The candidate will demonstrate a clear understanding of likely further management required by different MDTs. So the report made by the candidate should be clear, logical, and concise, may demonstrate knowledge beyond the core curriculum. So this is if the candidate shows all these criteria in the answer, then the candidate will be awarded 5 score. The candidate will be awarded 4 score if the candidate detects major findings, including those marked essential and most minor observation, makes correct diagnosis or differential diagnosis using clinical information provided, makes safe further management plans with clear recommendations, including MDT or specialist referral if appropriate. Report is clear, logical, and concise. So you know, band 4, score 4 and score 5, there is hardly any difference. Apart from that, the score 5 will be given to candidates who will demonstrate a knowledge beyond core curriculum. So we'll move on to score 3 and score 2. Score 3 is detects most major findings, including those marked essential and some minor observation, may or may not reach to the correct diagnosis. So here the diagnosis is important. Score 3 will be given to candidates who will not reach to the correct diagnosis but demonstrate sensible clinical reasoning. Like instead of saying osteomyelitis, if the candidate says some infection or some inflammation, then I think the score 3 will be given to such candidates. Then the if the candidate shows has written safe differential diagnosis, then the score 3 will be awarded. May not know full management plan but demonstrate enough knowledge not to compromise patient safety. So for RCR, patient safety, patient showing empathy towards the patient is most important. A report should be clear, although it may not be ideally structured. Score 2 will be given to candidates who fail to detect most major or critical observation, fails to make correct diagnosis or provide reasonable differential diagnosis, gives inappropriate further management, failure to refer to proper appropriate MDTs. And the report, if the candidate creates unstructured or scattergun report, then score 2 will be given. We'll not discuss score 1 because we are not here to go to score 1. We want to score 3 or more than 3 in order to pass this long part. So I'll just touch upon like what they are expecting from the candidate when the candidate is writing observation, interpretation, main diagnosis, differential diagnosis, and further management. So in observation, like we have discussed, the first candidate is going to write about lines and tubes, make and then write relevant negative positive findings, then the relevant negative findings. Interpretation, so the candidate has to write whether the lesion is benign, malignant, infective, traumatic, congenital, or some other etiology. But then in the interpretation part as well, the candidate has to provide reasons why the candidate is thinking like that. If the candidate is thinking the infection is more likely than neoplastic, then the candidate has to provide say few reasons. Only candidate can enlist 2 or 3 reasons why the candidate is thinking it is more of infection and not neoplasm. Candidate has to give a single diagnosis after interpretation. If the candidate doesn't know, then most likely diagnosis should be given. The differential coming to the differential diagnosis. So what the RCR people say, they say that the differential diagnosis has to be limited in number, and the report should indicate why these were less likely than the main principal diagnosis above. So the candidate has to write why this differential diagnosis is less likely, why the candidate thinks it is more of infection and not neoplasm. So here in differential diagnosis, in order to say that it is not neoplasm, candidate has to enlist couple of reasons for that. And in further management, appropriate further. So the word appropriate is important, because if you go through the previous examiner's model answer, they say that only appropriate investigation is needed if the candidate is writing all sorts of management in the last part, then they will deduct the marks, because there will be a huge number of patients waiting for them to get them scanned, right? So it will unnecessarily overburden themselves, and the time will also increase. Okay. So this the longs part is done now. Then I will move on to Dr. Bharat's side. Dr. Bharat, please.
Yeah, hello everyone. So today we'll be discussing a very new addition to the FRCR 2B preparation, that is the shorts. Uh, Shorts is currently, it's mostly just a part of the, means the preparation is not that different from what you prepare for your long cases, because it is short rapids, but you are supposed to write them in a way like you need to mention the management. In majority of the cases you need to manage, you need to say the abnormalities, and you need to mention about the relevant things like referral in shorts also nowadays. So yeah. So this is the new thing, not that different because the majority of cases will be like the rapids which is provided to you. So like you see rapids, you see cases like pneumothorax, fractures, abdominal radiographs showing presence of foreign body, showing presence of abdominal obstruction, bowel obstruction. So majority of cases will be like that only. But the thing is, you need to write a small report regarding each of the rapid. Okay. Yeah. So first things now they have removed the normals. So there is not going to be any normal radiograph in the current short sections which is present. There is not going to be any normal radiographs. So this is good in a way as well for many candidates who were struggling with the normals in rapid sessions, where there used to be normal radiographs and they used to overcall it, saying some subtle fracture. So there will be no normal. So your mind is clear that every radiograph which is shown to you is having some or the other pathology. Next thing is how you're supposed to write that report. It needs to be short and precise. Means if you have been provided with a case showing right-sided pneumothorax, so first things you are supposed to say is this is the right. Write it in a bullet form. Like you are supposed to say right pneumothorax. Then if you can see any other rib fracture, say there is presence of any rib fracture associated. Then immediate write the management, immediately pick up the phone, inform it to the referring physician, to the emergency. Patient requires to be taken to be looked by a to be looked by a patient requires an immediate ICD drain. So that much, 3-4 lines, not more than that, because you will not get more than that time. So the schedule which they have provided currently is there will be 25 cases which needs to be completed in 2 hours. So if you calculate, I think so you will need to finish majority of the cases within four. Each case should be completed in 4 to 4.1 minutes, not more than that. Now every case will be given a marks from 0 to 5 in each case. There will be no half marks. It will be 1, 2, 3, 4, 5. So 0 to 5 is the marking given in each case, leading to a total score of 125. So now the interesting thing over here is there is no passing mark. So previously, when rapids were provided to you in the examination, there used to be passing marks. Like you were aware that if you get a score of 6, then you are considered pass. But here they will be using the Angov standard setting process, which basically means that there will be a team of experts who will gauge the standard of that exam. They will see if that exam is what is the toughness of the exam, how difficult the questions are. On the basis of that, they will decide what is the optimal passing mark for this exam. So for sometimes the passing mark might be 100, sometimes it might be 110, sometimes it might be 90. Okay, just like I think so the 2A exams which we have given. In 2A exams also, we have a standardized setting process and there is no specific marking mark. Just like in physics and anatomy, the passing marks vary. So just like that, here also the passing marks will vary depending upon the toughness of the exam. And then they will decide that how much is which candidate has passed this particular exam. So what here we need to focus is just need to focus upon the speed is what I would suggest. Now they have given a very good breakthrough also, the breakup as well, that the radiographs which will be provided will be coming from chest radiograph, musculoskeletal radiograph, and abdominal radiographs. So they have given a good distribution as well. So this is quite transparent that how you need to prepare yourself for. There will only be one question from abdominal radiograph maximum, and remaining will be from chest radiographs or musculoskeletal radiographs. There is even a breakthrough of breakup between adult cases and pediatric cases. Like adult cases will be 75% and pediatric cases will be 25%. So since pediatric cases will be 25%, this is a big number. So what all cases can be there in shorts in pediatric cases? There can be Solder Harris fractures. then can be C-cams, there can be some cardiac anomalies like TOF, which can be shown on radiographs, there can be rickets, there can be scurvy, there can be cases of non-accidental injury. So you need to keep those things in mind and you need to prepare for them accordingly. Next thing is I have given what constitutes a perfect file for the examiner to give you a maximum 5 mark in that particular case. So all the major findings is what I'm saying. Some you can even go through the RCR website. The RCR website has given 5 to 6 sample radiographs which they will be asking in the examination under shots. Go through all 5 radiographs. They have given even an appropriate answer for each radiograph. Definitely, it's a must for every aspirant to go through that and see those radiographs for themselves to see what they are specifically asking for. So a perfect five, all major findings and minor observation. Major findings like in pneumothorax is the pneumothorax. Minor findings, next major finding is rib fracture. Minor observation are patient might be having some nodule in the lung on the left side. Okay, so those are minor findings. Next thing, you have to formulate a particular diagnosis. And if there are two diagnoses, then you need to give two differential diagnoses, followed by management. And then further management by different MDTs. This is just like longs, but a concise form of longs where you need to be very specific. You cannot give descriptive answers like there is presence of opacification in that particular region. No, you need to say this is consolidation, this is collapse, or this is cavity. So you need to be very clear and concise in whatever you are saying in shorts, because they will be judging you on that also. If you give a descriptive answer in longs, you in the shorts for that matter, you will lose marks, and you might even not get a 3 or 2 in that particular case. Okay. And then the last part is demonstrate knowledge beyond the core curriculum. That is actually equivalent to the excellent answer, which is expected in cases of Viva. Like if you give some, if you have provided some information which is in part in correlation with some recent advance, but it will be very difficult. Most cases will not have such kind of things, but uh, any cases, if you are aware of some particular specific recent advance, make sure to mention it. Okay. Now, so the important things which come to is the time management. I think so. The current short exam is completely based on time management and time management alone, because completing 25 cases, writing about the observation, about the differential diagnosis, about appropriate management will require good amount of speed. So you need to complete each case in not more than 4 minutes. 4 minutes, 25 cases, around 100 minutes, and 120 minutes is the exam duration. So you will get at least 20 minutes, because if you target 4 minutes, you will end up using more than 10 minutes, more 10 minutes more grace. So 110 minutes is what you will take, and then you might get 10 minutes to just review your answers if required, if you want to add on particular things or not. So how will we prepare for this? So practice writing reports as much as possible even at your place. You can even use your previous rapid radiographs, whatever is available to you. The previous radiographs, rapid radiographs, try to write them in the current short format with the management, with the current observation, with the differential diagnosis present. Because the previous rapids where we used to have a lytic lesion. So we used to just mention lytic lesion in the particular part, like in the ischial tuberosity or in the humerus. We used to just mention that there is a lytic lesion in the right proximal humerus. But in the current short format, if you get a lytic lesion, you are supposed to say lytic lesion in the right proximal femur, and considering the age of the patient, this might, instead of writing the entire considering the age, review the age of the patient if the patient is old, then this might be metastasis. Then you need to write that review the previous imaging of the patient. A complete a bone scan will be required to look for metastasis elsewhere or for the primary focus, and a PET CT or a CT scan, chest, abdomen, pelvis will be required to identify the source. And then you can write the management that patient might also require an oncological MDT referral. So these 4-5 lines are added, which you need to mention in such cases in shorts if it is asked. So it's a new format, and the more and more we try to practice it, the more and more better we'll be. So it's an exciting thing. The good thing is that there is no specific passing mark and there are no normals. So if the particular exam is difficult and it is generally considered difficult by the standards by the examiners, then even a marking score, if you get a particular observed score less than means what you think is ideal, you might make through because the examiner will consider the exam setting and will lower down the cutoff for that particular examination. Okay, definitely visit the RCR website. They have example cases over there. Do go through them. Even me and Dr. Vaiibhav will be planning very soon on our platform to have a shorts descriptive session where we'll try to provide you with radiographs which will be in correlation with the expected shorts to be asked in the examination. And we will ask you to just self-assess yourself by writing it in a particular time frame. So we will definitely update you about whenever we are going to in that session. So it will be very soon. Uh, so all the best. That was my part. Dr. Vaibhav, would you like to add anything?
If you guys want to ask anything, you can go ahead. You can write your questions in the comment section. We'll try to answer, or you can write it in our Telegram group as well. We'll be uploading this today's session on YouTube. So any of you want to go through it again, or if you want to discuss this new format with your colleagues, and if you have any doubts, you can uh, ask us, me or Dr. Bharat. So I think we'll see you on next Friday. We'll have our first session of every month, which is an open house session. So we'll see you guys there. If you don't have any questions from according to the new reforms, what do you say, Dr. Bharat? There, I think we shall conclude the session and we'll uh, see next Friday. Okay.
Yeah, yeah, sure, sure. You can
Yeah.
also contact on the Telegram group as well. We are available over there.
Okay.
Thank
Thank
you.
you, guys.
Thank you, Dr. Vaibhav.
Thank you.